the most important thing was lived experience engagement is critical at every step. So, whether you are formulating a research question in study design or participating in and monitoring the study as it's being conducted, all the way to how do we get the word out about this important work that we did together? That's really what was the core of the 10-step process.
Welcome to The Bridge, Your Health, Your Voice, the official podcast to the University of Maryland, Baltimore School of Pharmacy Patients Program. The Patients Program is the bridge between the community and researchers. This partnership is created to help researchers listen to the community's voice in order to build a bridge to an effective learning healthcare community. Here's your host, Paris Barnes.
Hi, everyone, and welcome back. My name is Paris Barnes, and I'm your host today. I'm an African American female with dark red hair and a long braid, and I have on a pink shirt and gold chains. And today we have with us Dr. Hillary Edwards and Dr. Daniel Mullins. We'll kick it over to Hillary first. Can you introduce yourself and let our listeners know what you have on?
Thanks, Paris. Hi, everyone. I'm Hillary Edwards. I am a non binary femme with short brown hair, white skin, and I'm wearing a black dress with a blue scarf. Daniel.
Hi, I'm Daniel Mullins. I'm a white male. I'm wearing a white shirt with no tie.
Perfect. It's hot these days, so we can dress it down a little bit. All right, so just to get everybody warm and welcome and ready for this, I always like to start these off with an icebreaker. So I'll start with you first, Daniel. Who is someone that you've met that made you feel starstruck? It could be someone famous or not.
That's a great question. Maybe Luke Cooper. Luke Cooper is a member of our steering committee. I remember the first time I met him and heard his story, I thought, wow, like this is a man who grew up with nothing and has really not only created an incredible business, but he spends his life now helping African American entrepreneurs do the same. And yeah, I thought it was really cool. He came to University of Maryland, Baltimore as one of our presidential scholars in residence. And I had the great pleasure while he was here to get to know him, and he continues to work with our program.
That's awesome. What about you, Hillary?
So when I was young, I would go with my dad to his professional conferences, and it was in teachers' unions and labor movements. And when I was in, I think, fourth or fifth grade, one of the keynote speakers was Hillary Clinton. And I got a chance to meet her. And it was the only other person, maybe still to this day, who shared my name. And there was a moment where I was shaking her hand, and everyone was like, Hillary, meet Hillary. And I think it was the first time that I saw someone that I had heard about and then was seeing in real life. And yeah, it gave me an incredible drive. I look back to this day where it's like these are some things where you see important women who have done leadership in community building and building relationships and working and improving policy. So that's my story.
That's cool. That's really, really cool. That's a flex. You should tell everybody you met Hillary Clinton. That's amazing. That's so funny. I'm not really a starstruck kind of person because I'm the kind of person that doesn't want to like freak out the people that I meet because then they won't talk to me. But probably maybe if I was slightly starstruck, this is gonna be so random. But from the show The Wire, there's a character on there named Snoop. I met Snoop one day and I just thought Snoop was the most amazing person on earth. They were down to earth. They had the same accent as me. They were from where I was from and they were on a major HBO TV show. So I met Snoop and I was like, "Oh my god, you made it." So I thought that was pretty amazing and I was starstruck cuz I just thought you made it. Like this is your first role and you did that and you remained on the show to the end. So pretty cool meeting Snoop. Shout out to Snoop. All right, so I'm gonna start it off with the first question for Hillary. So, can you give our listeners a little overview of the 10-step framework?
Sure. So we believe that people with lived experience, whether they are patients, care partners, community members, should be a part of the engagement process in any research life cycle. So whether that's you're coming up with your question to how are you going to build out a research project, how are you sharing those things? And so way back when, I think the original publication of the 10-step framework actually preceded the patients program, But the idea was that this framework spans the entire life cycle of a project, and those 10 steps each have a different purpose for coming together to come up with what is important at that step of the research process. So each step would have an advantage and disadvantage, their implications for time and resources. But the most important thing was lived experience engagement is critical at every step. So whether you are formulating a research question in study design or participating in and monitoring the study as it's being conducted, all the way to how do we get the word out about this important work that we did together, that's really what was the core of the 10-step process and gave us a roadmap for planning, doing, and delivering research in partnership with people with lived experience.
Okay, so you touched on this a little bit, how this kind of predates the patients program, but this is the heartbeat of our program. This is what keeps us pushing and doing the work every day. But I'm not a researcher, and I think everybody, all of our listeners know this. Paris is not a researcher. I do some research, but I do not come from the research world. That just wasn't my thing, and I didn't think I was going to do that career wise, and then here I am. But how do people use the 10 step if they're not necessarily a researcher?
Ooh. So, one of the things, and we teach this in the Patients Professors Academy in week 2, is recognizing that in any activity, really, whether it's and it might be research, it might be about clinical care from like diagnosis to end of life, it might be about policy, or it might be about planning a health fair in a community with your local businesses. There's the plan, you plan something, you do it, and then you share what happened. And so I think with the 10-step framework, we start, and best case scenario is that from the beginning, you're partnering. We often talk about how, from the work that we've done in the patients program, people really are tired, and Baltimore has a lot of helicopter research. It's people who've been funded to do something, they drop in, they say, we have your best interest in mind, they collect your data, and then they leave. And the 10-step framework says there are so many places for opportunity to connect with the communities that you want to serve, so let's start sooner. And I think that that's something that we forget is also too in the healthcare environment. People enter the health professions because they want to care for people. They don't want to hurt people, but a lot of people don't have the tools to be able to start that conversation, except when they have the funding to then have a task to go out into the community and do. And so, what I love about our 10-step framework is that no matter where you might be in that continuum, again, maybe you're planning a health fair at your local school with the local church, or maybe you are doing a research project, or you're new to the field of social work and you just want to listen to community voices to figure out what services need to be available. There's a way to first listen, and we talk about those different steps in the listening and prioritizing what's important to those you're partnering with, then doing in partnership and in collaboration with those who helped you get to what was important to them. And then how do you not just publish in a paper or go to your presentation for your national conference, but really talk about how do we share this incredible work and this relationship that we've built over the duration of this project? And then, some people say like, "That was a great experience, see you on the other side when another opportunity rises." But there's also the opportunity to say, "What's next? Where are we now that we weren't a year ago when we started this project? So what new resources and what new agenda items do we have in order to leverage this incredible partnership that we've built towards sustainability?" And I don't know if, Daniel, there's anything else you wanna chime in because 'cause you've also been doing the 10-step framework for longer than me at this point. So, what do you think?
Well, I mean, even the 10-step framework itself was co-developed with our community partners back in the day, as you said, before the patients program actually existed. And then what was cool about that is that was the essence of the proposal that we submitted for the large federal grant that brought the patients program into existence.
This concept to me just seems simple, very common sense, but we're not seeing it done, you know? So, Daniel, what was the original motivation behind creating the framework and kind of why did you feel like it had to be formalized?
Most of us as researchers follow what other researchers are doing. And when I first came into academia, it was fairly commonly accepted that this idea of what's called community-based participatory research, or CBPR, was a better way to do research. And at that time, it was considered novel that instead of asking patients and community members to come into an academic institution, come into the academic ivory tower, that perhaps we should bring research out and research should be done in the community. That was pretty well established, lots of literature on how to do that. But there was a growing concern amongst many of us that simply bringing an academic research project into the community so that it was based in the community wasn't enough. That really, if we were doing something in a community, that it should be with the community and not just in partnership after we decided what we were going to do, but that the better way to do research out in the community was to bring the community in as partners in developing the research project. At the same time, a lot of patients and community members don't know much about research. And so we spend some time talking with community partners we've been working with about what are the various steps that occur in an ideal world in which patients and the public have input. And the idea was that we first might start talking about all the types of research questions that could be answered and then prioritize that. And so if you look at those first two steps, it was recognizing that oftentimes the research question is from an academic perspective or from a researcher perspective. And so we sat down with our community partners and we really mapped out these 10 steps that occurred. And it was a conversation over a series of weeks. And then eventually we came up with names for each of those steps. And so here's the humorous part. At the almost end of the exercise, where we had all the words right, we put it up on a whiteboard and there were only 9 steps. And we all kind of agreed that you couldn't have a 9 step framework.
Yeah, that's odd.
So, yeah, so don't ask me how we did it, but back then we ended up taking one of the ideas that really was a complex idea and realizing those were actually 2 separate steps. And so, yeah, if it weren't for that back and forth discussion and group consensus, we might be teaching the 9 step framework today, but in fact, it's a 10 step framework. So that's the origin of really sitting down, having conversations about how research should ideally be done, and then delineating those 10 steps. But then the question was, what do we do at each of those steps? How do we engage patients and community partners and community clinicians, policymakers, health systems administrators, other researchers, government agencies, et cetera, in helping us to really redesign the research from a patient-centered lens.
So when people want to use this in practice, and yes, there's 10 steps, and the idea is that maybe you should use them in order. How are we using the same steps every time for patients and partners? Like, is it the same type of song and dance for the whole go round, Hillary?
So I think we often joke from the academic side. I'm going to joke or tease where there's this assumption of we need to meet the community where they are. And I think at this time, 10 plus years into using the 10 step framework, it's actually about meeting the researchers where they are and bringing them in to the work that we do. And so one of the things is like, yes, some people are at different steps of like how much they are ready to partner. And meaningful engagement does not mean that you have a community member who is a co researcher. And to some extent, that might be very suspicious if you've just had one conversation with someone and you're bringing them in. And so there are different ways to engage different members, both of a research team, but also different members of the community at different steps. And each of those steps, and Daniel highlighted a few of the differences between, early steps where you're really listening and getting feedback and then prioritizing what's important. That takes a different level of resources than maybe you finished the research, you're translating it to various audiences who would be interested to know what you found out and how do we get it out into the world. And so we did a project that was funded through the Patient Centered Outcomes Research Institute uh, several years ago at this point, where we had a game board and we had the 10 steps, and then we took 10 evidence based methods for community partnership and patient engagement. And we asked researchers, community members, people who had participated as co developers from the patient or care partner perspective. And we had about 150 individuals complete this game board to show where they felt those methods mapped best to the different steps. So, we again, and I have actually thought about doing a search in the literature because patient engagement, patient-centered outcomes research is so much more publicized and documented now of what people do to demonstrate meaningful engagement. And so we had this game board activity, we looked at the data, and to some extent, there's no doubt that community partnership and people participating as research team members is the most deeply meaningful ways at any step of the process. And we really demonstrate that through all of the work that the patients program does. I don't think there's a single project. Don't challenge me on this, Daniel, but I'm pretty sure I've been here long enough. There's been a single project where a person with lived experience has not been front and center in the steering of the project or the program. We also recognize that not everyone has the resources that the patients program does. And so maybe having storytelling sessions, or maybe having a town hall, maybe having a focus group or an interview, that's not the research conduct itself. It's about the planning and the advising of the work. That's when those methods can really be impactful at different steps. So, a focus group or an interview, we found that those were really important for people who are trying to identify what the most important research questions were and how to phrase those questions in the voice of someone with a lived experience. How would you tell a loved one? How would you tell someone who does have 6 degrees, but they're not in anything that you're studying, um, what the question is in the patient voice? And then we have, again, different steps, and I'm happy to share a link to the article where we publish this information. And where there was less evidence does not mean that it wasn't a meaningful way to get information out or to engage individuals, like print material or surveys, which are very unidirectional in some ways, right? They're not conversations, but there could be a place for them. And so at the end of the day, there's no one size fits all approach to patient engagement. And the first step is always to listen. Maybe for a particular population or community, print material is the way to get information out to them, to build trust, to then be able to have a bi-directional conversation or a convening where you're collectively working together to construct something. Daniel, I don't know if there are other thoughts that you have since we worked on that project together.
Right. First, yes, that project really helped to understand that just because a method of engagement is evidence based, it's not always appropriate for every project at every step. The other thing, Paris, you asked though about do you always do all 10 steps? Um, and so the honest answer is no. But the aspirational answer is yes, which is I do believe any project should always go through those 10 steps. The pragmatic decisions that we make is if somebody, for instance, is a cardiologist, a person who deals with heart disease as a research area of interest, that individual is unlikely to want to switch over to, say, doing a cancer study because they don't have that background. And so we do have to make practical considerations that rather than saying what are all the questions that we might answer if we're talking with a researcher with particular expertise, we would put some guardrails around the discussion and explain to patients that this individual's, open to ideas in this space, but not completely somewhere else. Um, and then how we accomplish that is oftentimes finding patients who are generally interested in that research topic to avoid that. Um, the other reality is that we sometimes have people who, for instance, may have submitted a letter of intent to a funding agency, are now asked for a full proposal. And so, in some ways, they've already decided, in a general sense, what their question is. And so, the only way that we can influence that now is to bring patients and others with lived experiences in to help reframe that question in the patient voice, right? So there are some aspects of that. The other frustrating part of this is many funding agencies want you to disseminate, but they don't provide additional funds to support the dissemination activities. And so I think that leads to um, less dissemination activities than great ideas that come up from our patients and community partners about what we could do if we had additional funds. And the conversation is always one where we explain that there sometimes are time constraints or budget constraints. And most of the patients we work with understand that they have that in their daily lives. So we don't always do all of the 10 steps, but I think we try to always do that. And then if a researcher comes to us and we feel that that they really don't have an interest in doing all of those, we might still try to help them move along their journey. As Hillary said, meet the researcher where they are. But as part of the patient's program steering committee standard operating procedures, if our steering committee, which is mainly community leaders, doesn't like the idea of a project, we won't fully support that project, or we won't even partner at all on that project. And so there's a difference between trying to educate researchers to be more patient-centered and then actually getting behind somebody's proposal. And that second step requires an oversight from our steering committee.
Mm, that makes a lot of sense. And I think it's important for our listeners as well as researchers, if you're out there, to understand that it is imperative that this is done. It makes better research. It's more well rounded. Your community is behind you. And the misconception is that people don't want to participate. And that's not the truth. People are 100% interested in participating in things, but they have to feel like they're a part of it. And through this process, I can speak highly on the Patients Professors Academy because this is what I do. That's my bread and butter. But that's what we do. We teach the 10-step framework so that we know that people are at least disseminating out what we taught them to their communities and they're implementing it in their work. And in doing so, we decided that we needed to make a slight refresh to the way it looked. So, Hillary, can you kind of go into some details about the refresher for how it looked? And then afterwards, I'll kind of tell you the design process.
Absolutely. Yeah, it was such a pleasure working with you, Paris, to update the visual because I mentioned earlier that this 10-step continuum was a roadmap. And when you looked at the roadmap, it started with step one, which is right, listening to solicit what's important to people with lived experiences. And Daniel also mentioned that oftentimes people come to us and they are well on their road where they have a trial funded and they can't recruit anybody and they're trying to figure out what to do. And so when I would talk in the Patients Professors Academy, and we'd get these questions, like the question you just asked, we get it a lot where people are like, well, what if I'm already on this journey? Or I already have a community advisory board, but I don't get feedback from them in the way that I wish I was really getting good feedback. What do I need to change? And so we realized that it actually would be more like a roundabout instead of a roadmap, is that people are entering the continuous 10-step framework at any step. And so how do we then not say, okay, we haven't cut off the first three steps because you've already been funded. We're just starting from a different place. And then when you finish whatever that project might be, the last three steps are actually the planning for the next thing. And so I loved when we were, and one of the other things that I will take a step back and also reflect, we're going into our fifth year of the academy. The number of people who have been taught the 10-step framework and the questions that they ask or the reflections that they have demonstrated to us that the model needed to change, but the framework does not. Right? So the roadmap as it was, we needed to change to a roundabout to show that, yeah, you can enter the 10-step framework at any step. And the resources at that step might be different than if you were entering at a different part of the roundabout. But that doesn't mean that the cycle ever ends. it is continuous. And so I loved that we were able to reframe that for our patient partners, our staff, others who have already been introduced to this new visual have said that it's been really helpful to then actually make it feel more accessible to enter the 10-step framework wherever you are on that sort of readiness to partner and meaningful engagement scale. And the other thing, as methods, as evidence around engagement has, I would say, leveled up. Again, the volume of information that's out there now, there's a lot of questions, especially from the Patient Centered Outcomes Research Institute, is about the meaningfulness of the partnership. And so the other, Daniel mentioned 10 steps. We actually have an 11th step, which we don't say, but it's evaluation. And so I love in the roundabout, we sort of have a traffic cone or something that sort of surrounds it that's about the evaluation of the partnership. It's not, did we do a good job, as much as it's about what is working, what are the resources that are ensuring that we continuously remain partnered at all these steps when there might be different um, desires or when things change. But it's sort of like the construction zone, is that there might always be a little bit of construction, but the hope is that you're always going, staying on the road, if you will. But Paris, again, you've spent a lot of time looking at this graphic and the revamp. So what did I miss?
It's kind of funny. As I was working through making the graphic again, I almost had to use the 10 step myself to make the graphic. So it's kind of funny because it was really ironic. And like Hillary mentioned, yes, we collected feedback. So we sent out a couple of different iterations, not just to the authors of the paper, but we sent out a couple iterations of this design to patients, professors, so they can give us serious, honest, clean feedback on what they thought. And then we did this before we presented it to our team to be able to give honest and clean feedback about what they thought. And then my graphic design thing is very different. By the time I get everybody's feedback and I kind of look through it, I probably already made 10 versions of it before it gets to you anyway. So the version that was presented was probably about version 11 or something. And I took everybody's feedback, and I'm a girl that sits in my office with my music on or a podcast. So I turned my music on and I read through all the feedback from everybody combined, in terms of content as well as the way it looked. And then I got to work. I just kind of sat through it and kind of conceptualized what makes sense. I come from a marketing background, so I do have a better understanding of what makes sense to people from that standpoint. So I do think that that almost benefits me in the research world because I have a different, more worldly view of certain things. So I knew aesthetically what would make sense to individuals looking at it, but I just wanted to make sure that in creating this imagery, that it was something that could be utilized in both settings, and no matter what your education level, no matter what colors you like, it would be something that would be visually pleasing and you could understand. So that was kind of the thought process behind it, but totally ironic. When I was creating it, I almost had to use the 10 step to create the 10 step. So that just goes to show you don't have to use it for, health if you don't want to. I was able to use it for a creative marketing standpoint too. Kind of worked for me. All I did was adapt some of the terms to turn them into what worked best for me.
There's a couple of things about engagement evaluation that's important. One is through engagement, we evaluate whether the project itself needs to be changed. And so, as an example, when you talk about the outcomes that you're going to collect, and then you talk about the data collection process, there's an iterative back and forth where if what you want to collect is too burdensome to patients, then you might need to revisit, how you, are going to select the most important outcomes. Or if there are some outcomes that could only be assessed, for instance, by having an office visit to draw blood, then if you were thinking about doing all of your data collection online, then you have to rethink that. So that gives some concrete examples of that. Another one is if in discussing with patients what we're going to disseminate, you suddenly realize that we wouldn't be able to disseminate the answer to that question because our data collection process wouldn't give us the data to be able to meaningfully answer that question. And so then we either have to not disseminate that or we need to think about additional data collection, but then that gets back to, but then is that going to be too burdensome to patients, right? So that gives you some sense of how it is you jump back and forth. But the other part, and the part for why, as Hillary said, this, what would have been the 11th step isn't called the 11th step is you should also be evaluating how you engage your advisory board members. These are the patients, the community clinicians, and community partners, others who are providing you advice. And and oftentimes when I ask a researcher who says that they do patient-centered research, what part of your protocol changed because of what your advisory board members said? They don't have an answer. And so I said, if you can't tell me a couple of things that you did differently because you were getting advice from patients, care partners, and others, I don't think you're really authentically applying a patient centered approach to doing research. And that's the aha moment for researchers, which is it's not about talking with patients and hearing about their journey as a fun activity. It is about making research more patient centered. And if you're making it more patient centered, something should change because of what you heard. It shouldn't just be a fun activity.
So, in doing this, how does a 10-step engagement framework connect to the recent PCORI of Science of Engagement Award, Daniel?
Thanks for the question. As I mentioned earlier, there is this importance of evaluating whether you're engaging patients and other community advisory board members in a meaningful way. PCORI introduced a new PCORI funding announcement, or PFA, called the Science of Engagement, and it is about developing and or testing methods of engagement. What we decided to do was to specifically focus on community advisory board members because those are individuals who are supposed to be with you from the development of your proposal all the way through the dissemination. And so, while individual patients should be meaningfully engaged, oftentimes an individual participant in a study only comes in for one or two appointments. And so, understanding whether that was a meaningful experience is kind of hard to assess because it might really be about whether the person who greeted them was friendly. But an advisory board member who's really helped to develop a proposal, provided advice to the principal investigator throughout the project, and then helped to think through how to disseminate it. If that person doesn't feel that their presence and their voice made a real impact on that research project, I think that's a problem because then it's tokenistic engagement. And we have heard that there are still researchers who say, well, I don't really know that I changed anything because of what I heard. And we've heard patients who say, I was an advisory board member for several years, and I don't think people were really listening to me. What we're trying to develop is a tool that would be valid and reliable to measure from the perspective of a community advisory board member whether they felt that they were meaningfully engaged so that they could rate their experience in being engaged as an advisor to a research project. And 2 years from now, we will have developed this tool that we believe could be used by researchers to get an honest assessment of how they're doing. And not so that you would say that you're doing a good job or a bad job, but that would help you to understand where you could do a better job, right? And so we always say, it's not where you are, it's where you're heading. We want researchers with good intent to be more patient centered in the future. And this tool would allow them to get honest assessment from their advisory board members about when are they actually meaningfully engaging those advisors and where could they do better.
So the proof is in the pudding, y'all. We are doing the work. We are a very busy team. We are doing the work, and it's often cumbersome because it's a lot of work, but it is very exciting because we know at the end of the day we're doing what is best for our community and in research. So thank you so much, Daniel and Hillary, for being here with us today and explaining this to our listeners. Follow along with us on the journey. Follow us on social media. We're always up to something. Patients Professors Academy is get ready to kick off soon. So stay tuned and you'll hear a lot more about the work we're doing. Thank you so much, and we'll see you next time on The Bridge.
Thank you for listening to the Bridge podcast. To learn more about the Patience Program, visit our website at www.patience.umaryland.edu.